In this video, I want to look at two big things. Number one, what does a typical therapy session look like for BPPV? Now remember, BPPV is an acronym for benign paroxysmal positional vertigo, which is the most common type of vertigo that you're going to see in the clinic. And the second big thing is I want to talk about self-maneuvers and how they fit in with a typical BPPV plan of care. So you have a patient that comes in for an initial evaluation and they're complaining of dizziness. Some common things that you'll hear when the patient actually has BPPV is they'll say that there's a visual change with the room spinning. They may not volunteer that information, but that's an important thing to ask. Do you have a visual change with the room spinning? If yes, there's a good chance that they have BPPV. Oftentimes people that have it have had it before, and they've had some kind of physical therapy treatment for any one of these diagnoses right here, and it's helped. If they've had previous successful treatment for BPPV and they're coming in again with the same symptoms, it is very likely that they have BPPV again. So you go through the diagnostic maneuvers, Dix-Hallpike maneuver and the horizontal roll maneuver, and you diagnose the patient, and it could be any one of these things right here. We're skipping the cupulolithiases just for simplicity. So it could be posterior, anterior, or horizontal canalithiasis. And so based on the diagnosis, you give a treatment. If it's a posterior canalithiasis, you give them the Epley maneuver. If it's an anterior canalithiasis, you can give them the Epley maneuver, but also the deep head hanging maneuver. And then if it's a horizontal canalithiasis, you give them the barbecue roll maneuver. Okay? And that's your first treatment session. And generally speaking, I always do 2 repetitions of whatever the appropriate maneuver it is, with a 5-minute rest break in between the 2 repetitions. Okay? So that's your first treatment session. So you deliver these maneuvers, and then comes the end of your first treatment session, the end of your initial evaluation. If this was any other branch of physical therapy, whether it's orthopedic, pelvic, neuro, inpatient, even other vestibular conditions, you would certainly give a home exercise program, or HEP, to the patient, right, that targets their impairments. Makes perfect sense. However, we do not do that with BPPV. Okay? Now, it's always possible that this vertigo exists with a second diagnosis, like low back pain. And if they have low back pain, you can certainly give exercises for that. But specifically for the BPPV, you do not need to give an HEP. So those self-maneuvers are not necessary. Oftentimes, patients will have seen a doctor, and the doctor refers them to physical therapy, and the doctor already gave them a handout or a sheet that explains usually the Epley maneuver, because it is the most common maneuver that we do. But you need to instruct the patient after this first treatment session, they do not need to be doing that maneuver. There is no homework for them to do. And one of the reasons these self-maneuvers are not necessary is that they can be detrimental to the progress of the treatment, especially when they're not performed correctly. So you'd be surprised how many patients are not able to effectively execute motor patterns necessary for these maneuvers. If we look at the Epley maneuver, there's a roll involved into sideline. In the barbecue roll, there's even more rolls. I mean, you're going all the way from supine to prone and then all the way back over again. So if the patient can't roll, the Epley is going to be difficult. The barbecue roll is going to be practically impossible, okay, and possibly unsafe. Other considerations might be limited neck range of motion. If you're doing, in particular, the barbecue roll, the patient has to have 90 degrees of cervical rotation, right? And if they don't have that, they have to compensate by rolling at the thoracic spine to achieve a net 90-degree tilt of the head. That's going to be difficult for a lot of patients. So for these reasons and more that we cover in other videos, it's not necessary and probably not indicated to do these at home, okay? You're still going to get the patient better in a very minimal amount of visits, even if they don't do these, okay? So hopefully that's perfectly clear. So then they come back for the second visit and they report a global rating of change of 30%. They're getting better. So as long as they're getting better, there's no reason to change the treatment. You just do 2 more repetitions of whatever maneuver is indicated, the same ones you did last time. And then, again, no homework. They come back for the third visit, global rating of change of 70%, so they're getting even better. Again, don't fix something that's not broken, okay? you're getting them better with this maneuver. So just do 2 repetitions of the same one you did the last time. Okay? Once again, the patient goes home. They come back to the next session and they say, you know what? My symptoms are gone. Symptoms are in remission. I haven't had any dizziness, vertigo episodes. Global rating of change 100%. What does that mean? Physiologically, it means we've taken those crystals that were in one of these canals right here, and we have moved them back into the correct spot, into the utricle. So we've already moved them all out, right? They're in the correct place. There is no more need to do any of these maneuvers when they say that their symptoms are totally gone, okay? So the patient's in remission, they are appropriate for discharge. One thing I hate doing is wasting patients' time though. The patient drove all the way to the clinic just to tell me that they're all better, okay? That being said, I hate wasting their time, so I want to do something useful in session, but they also paid a copay most likely, so I hate wasting their money too. So we need to do something in the last session, and in general, it boils down to patient education, okay? So the patient's in remission. They're going to go home and hopefully be rid of their symptoms forever, but with vertigo, there's always a chance that those symptoms can come back. BPPV can relapse. But for now, they're in remission. And as long as they're in remission, they need to understand that there is still no need to do any of those self-maneuvers. Again, the maneuvers in general are for putting the crystals back in the right place. The crystals are already in the right place. They don't need to do any self-maneuvers, okay? But let's suppose they're just minding their own business and 5-10 years later, they get vertigo again, okay? The symptoms are very similar to what they had before, if not the same, okay? So the patient at that point needs to understand that they can try a self-maneuver. And this is what you need to discuss with them at the last session. That self-maneuver is going to be based on their most recent BPPV diagnosis. So if going through all this, let's say they had a left posterior canalithiasis, they need to understand that if they relapse, their best bet is to try the treatment for a left posterior canalithiasis, do a left Epley maneuver. So what I will do is I will send the patient home with a little packet, a handout with written instructions. I also give them a video demonstration specifically of the left Epley maneuver. I make sure it's not the right. Now, if it was a right canalithiasis, I would give them the right Epley. But this was a left, so I'm going to give them a video explanation of the left Epley maneuver that they can do at home. However, the patient does need to understand that even though the self-maneuver we give them for the future is based on their most recent BPPV diagnosis, there is no guarantee that this maneuver will help them if the vertigo comes back. And the first reason we've already talked about, there's no guarantee that they're going to perform the maneuver correctly. I mean, if the vertigo comes back 5 or 10 years later, I mean, try thinking back to what you did in therapy 5 to 10 years earlier, especially if you're not trained in physical therapy, right? It's going to be hard to remember it exactly. And even if they have the video, again, there's no guarantee that they will do it correctly. The other reason is probably the more important reason. There's also no guarantee that the canal is going to be the same, okay? So if somebody comes in with a left posterior canalithiasis, we treat it with a left Epley maneuver, and we would send them home with understanding how to access information on a self-left Epley maneuver. But if the vertigo comes back, it could just be a different canal. It could be the horizontal canal this time. Or it could be the right posterior canal, in which case, again, that left Epley maneuver is not going to be effective at treating. Now, before you start thinking that these self-maneuvers are hopeless, they do help some people. They may not completely get rid of the symptoms, but I've had plenty of patients that have done self-maneuvers and it's helped maybe 40%, 50%. It just doesn't get rid of it totally, okay? So they can be useful. But what the patient really needs to understand is to be mindful of their symptoms if this happens again, if you get relapse. So if the symptoms are the same or they're at least similar to what they had before, go and seek out physical therapy quickly, right? You already know physical therapy helped before, so go do it again. Get in as quickly as possible. And then do that self-maneuver in the meantime just for management. It may not get rid of your symptoms totally, but if you can even improve your symptoms 20 or 30%, that's still something. that makes your life more manageable in the meantime before you get into physical therapy. Okay? So hopefully this video gave you a good understanding of a typical BPPV therapy session and also the utility of self-maneuvers and when they should be involved in physical therapy. Thank you for all your support. Be sure to check out my Instagram for cool science and not science stuff.